Diffuse neuronal and axonal injury, according to this person, diffuse brain damage exists in four physical principal form: diffuse vascular injury, diffuse axonal injury, hypoxic brain damage, diffuse brain swelling. Diffuse vascular injury consists of multiple small hemorrhages throughout the brain, is virtually restricted to patients whom die within 24 hours, whereas the later three are encountered in patients who survive long enough to reach the hospital. Recent research and a new immunohistochemical method have shown that traumatic axonal injury is much more common than previously realized. And that axons can also be diffusely damaged by other processes than head injury. Therefore, suggested that new definition of terminology indicated the inherent use of terms in literature. Axonal injury is a non-specific term referred to damage to axons of any etiology. Traumatic axonal injury is a damage to axons caused by trauma, which may vary from small foci of axon to more widespread brain damage. Diffuse traumatic axonal injury is the most severe form of a traumatic axonal damage, originally termed diffuse axonal injury. Diffuse axonal injury, first described as a clinico-pathological syndrome of widespread axonal damage throughout the brain, including the brainstem, should not be used as a term without the reference to the etiology, because axonal injury may be caused by other pathological process also. Experimental work has suggested that diffusion axon injury is primarily a non-impact rotational acceleration deceleration phenomenon, deformation by stretching probably being the most significant factor. A low level of injury causes transient changes in the permeability of the axolemma, gradually leading to ionic changes, accumulation of fluid and axonal swelling, and eventually, with an increasing grade of injury, to intracellular calcium accumulation, proteolysis, and collapse of the cytoskeleton. Disruption of the axons leads to bulbous and clubbed retraction balls and globules in the globes in the axons in the cerebral hemisphere, cerebellum, and brainstem. Disturbance of axoplasmic transport causes accumulation of substances in the damaged axon that can be demonstrated immunohistochemically. At present, beta amyloid precursor protein is considered to be the most reliable indicator of axonal damage, revealing axonal injury within 2-3 hours of the insult, where it takes place about 12 to 18 hours for axonal bulb to become visible on routine or silver stains. However, one should keep in mind that beta amyloid precursor protein is not specific to head injury, but it is an indicator of derangement of fast axonal transport, which has been demonstrated in other pathological conditions. It is preferable to examine the brain after proper fixation, usually after 10 to 14 days in a 4% buffered formaldehyde wherever possible. Consultation with a neuropathologist with experience in forensic practice. Due to the diffuse nature of the axonal injury, extensive and systematic sample is essential, as the diagnostic yield is directly related to the number of blocks taken. In addition to any obvious focal pathology, the minimum set of samples should include corpus callosum with the parasagittal posterior frontal white matter, splenium of the corpus callosum, deep grey matter to include posterior limb of the internal capsule, cerebellar hemisphere, midbrain including the decussation of the superior cerebellar peduncle and pons including superior and middle cerebellar peduncle. In addition to this, it may also be advised to include a corpus callosum with the parasagittal anterior frontal white matter and temporal lobe including hippocampus. Retraction lobes are most numerous in the corpus callosum, the superior peduncles and parasagittal white matter, medial lemniscate and the corticospinal tract, but it can be seen anywhere in the white matter. The retraction lobes or axonal bulbs have been shown to lose positive staining for beta amyloid precursor protein for about 1 week, but to persist in adjacent varicose axons up to 30 days. After some weeks, in those who survive long enough, clusters of microglia, presumably as part of a repair process, congregate at the site of ruptured axon. These are best seen in 20 micrometer thick sections stained with crescale violet or more specifically using CD68 or IBA1 immunostaining. One problem with the microscopic evidence of both microglia clusters as well as diffuse axonal injury, as demonstrated by beta amyloid precursor expression, is that neither of them is as specific as a marker of trauma. Retraction of globes may also be seen around the periphery of natural lesions such as cerebral infarct, and hemorrhages and microglial structures have been reported in viral and human HIV encephalitis, previous global hypoxia, and fat embolism. conclude their excellent review that demonstration of traumatic axonal damage is likely to be limited use in for most forensic situations, except perhaps to confirm that there has been a head injury. Thank you.